Videolaryngoscopy, troubleshooting for nasotracheal intubation, anatomically covered. Your tube is in the nose, but still you are not able to negotiate the tube inside the larynx because of laryngeal impingement, or if tube is sliding into the esophagus. How to overcome this impingement? Look at this video. In this video, endotracheal tube, nasotracheal tube is impinging over the right area epiglottic fold. I'm showing it again. It's impinging on the right area epiglottic fold. So in such case, before advancing the tube, withdraw the tube little bit and do a anti-clockwise rotation. Make the tube trajectory towards the larynx. Advance the tube, and once you are inside the larynx, rotate the tube towards the right side. This will overcome this right area epiglottic impingement. Many times your tube is sliding into the esophagus. How to take the tube inside the larynx? For that, there is one technique. You have to inflate the cuff, or withdraw the tube little bit and inflate the cuff in the pharynx. This will take the tip of the tube anteriorly and then advance the tube by deflating the cuff. Here, I am showing the video. So I am withdrawing the tube a bit, then inflating the cuff. Once I am inflating the cuff, it will take the tip trajectory towards the larynx. Advance the tube inside and then deflate by deflating the cuff. Now what happens? Many times, once you deflate the cuff, because of tube trajectory towards the anterior part of the larynx, it hits the anterior tracheal or anterior laryngeal wall. You are not able to negotiate the tube further. In such case, rotate the tube right side, will overcome this impingement, or make slight flexion of the C-spine, or give external laryngeal manipulation. By these three techniques, you will be able to overcome the anterior impingement in the nasotracheal tube. So another way to make use of Bodecker forceps is having a two curve, one and second curve. Let's compare it with the Magill's forceps. This one is Magill forceps is having only one curve, while Bodecker's forceps is having two curve. Now, suppose you are using the Magill forceps with the videolaryngoscope. So when videolaryngoscope in situ, the camera takes the position in the pharynx. And if you are inserting the Bodecker forceps like this, the tip of the Bodecker forceps will not come in the view of the camera, so you will not able to see the tip. So it's made difficult to hold the tube with the tip because you are not looking at the tip. But when you are using the Bodecker forceps, because of its having two curve, tip is just in front of the camera. You will be able to visualize the tip of the Bodecker forceps and take the grip of the tip of the endotracheal tube with the Bodecker forceps and advance the tube inside the larynx. Look at this video. Here, holding the tip with the Bodecker forceps because of two curve and then advancing the tube inside the larynx. This is how you can make use of Bodecker forceps when your tube is getting impinged or tube is sliding down into the esophagus. In spite of doing all the maneuvers, if you are not able to negotiate the endotracheal tube into the larynx, then you have to deploy a hybrid technique. What you have to do? Through the endotracheal tube which is passed from the nose up to the pharynx, pass the flexible endoscope through the tube, keeping the videolaryngoscope in situ, then negotiate the scope inside the larynx. This is the videolaryngoscopic view. And over the flexible endoscope, build the endotracheal tube inside the larynx. This is how you can overcome the different troubles with the nasotracheal intubation.